Important factor that we have mentioned is the magnesium level alterations. Both hypo and hypermagnesemia can result in hypoparathyroidism. So many of the patients with anatomical hypoparathyroidism, like post-surgery patients, may also have concomitant hypomagnesemia. So if you correct hypomagnesemia, you can actually improve the calcium levels, and you can also reduce the required doses of calcium and activated vitamin D. So you check the calcium as well as magnesium, and if the magnesium is found to be very low, you give an IV correction, but it is not often required. It is only slightly reduced, and you can correct it with oral supplementation only. If it is very severe, say it is less than 1 milligram per deciliter, you can give an IV dose of 2 grams of magnesium sulfate infused over 10 to 20 minutes, followed by 1 gram in 100 ml of fluid per hour. So that is the typical regime for IV correction of magnesium, which is most often not required for management. It is given only if the patient is suffering from severe hypomagnesemia. So magnesium repletion should be continued as long as the serum magnesium concentration is less than 0.8 milliequivalents per liter. So as long as it is less than 0.8, you will have to continue the magnesium infusion, and when it reaches to more than 1, you can convert it to oral supplementation. So always when you are giving IV, you should make sure that the initial value was correct and the patient is not developing rebound hypermagnesemia, because hypermagnesemia can result in neuromuscular toxicity, and the earliest sign of hypermagnesemia is loss of knee jerk, loss of patellar reflex. So that is how you identify from clinical examination the clues of hypermagnesemia. And once the IV correction is over, you can bridge it with oral medication by using 300 to 400 milligram in divided doses, in 2 divided doses. That is how you correct hypomagnesemia.